Good afternoon, everyone. My name is Kim Stevenson, and I'm Director of Workforce and Clinical Affairs at the Massachusetts Health and Hospital Association. I want to welcome you to today's Caring for the Caregiver webinar, bringing the group peer support MASStrong program to your community. As a reminder, all Caring for the Caregiver webinars are recorded and added to our Patient Care Link website, and we'll put the link in the chat for those so that you can see previous recordings as well as this one once it's added. And additionally, slides will be shared with attendees following the webinar. A few logistics before we start. If you have any questions during the webinar, please enter them into the chat feature as we are in listen-only mode. The questions will come directly to us and we will do our best to address as many of them as we can at the end of the presentation. I also want to take a moment now to thank MHA's 2025 annual sponsors and strategic partners for their support in underwriting today's webinar, which is just one of many events we offer throughout the year to connect our members with leading experts to help address timely issues like the one today. I'm pleased to introduce our speaker for Group Peer Support, GPS, today, Liz Friedman. Liz is the CEO and co-founder of GPS Group Peer Support. She leads a national movement to bring accessible, trauma-responsive, and culturally rooted group mental health care to communities that need it most. Liz currently oversees the MASStrong program, supporting healthcare workers across Massachusetts with peer support groups, facilitator training, and funding infrastructure. She's also helped shape landmark maternal and disability rights legislation. Her work has been nationally recognized by TED Women and featured in award-winning documentaries on perinatal mental health. Thank you so much for being here today. As we're looking forward to this discussion, I will hand it over to Liz now to get us started. Thank you, Liz.
Oh, thank you so much, Kim. It's a pleasure to be with everybody. Welcome. We're going to be talking about bringing MASStrong to your community. I'll tell you about GPS Group Peer Support, how you can bring these resources directly to your organization and the communities you serve, and why it really matters at this moment. Let me start by sharing with you our sponsors and our partners. Getting a handle of the slides here. First, I want to just recognize our partner organizations, the Betsy Lehman Center for Patient Safety, Smith College School for Social Work, and Stony Brook School of Social Welfare, both are research partners for us in continuing to build the evidence base for the GPS Group Peer Support model. I also want to recognize our partner organizations, including, of course, Mass Health and Hospital Association and other organizations across Massachusetts who are excited and partnering with us to ensure that the MASStrong program is in the hands of healthcare workers and the communities you serve. Today, our agenda for our time in this webinar, I'm going to give you an overview of the MASStrong program. I'm going to talk about the situation for healthcare workers and for healthcare organizations, none of which is going to be really a surprise to you because you're living it, right? And then we're going to talk about the impact of the MASStrong program and how to participate. And of course, we'll have some opportunities for questions and answers, and I will be available after as well through email if you have any questions and want to connect further. All right, let's jump in and let's get started here. First, I want to tell you about the MASStrong program. So the program is all about strengthening healthcare providers and strengthening our communities. This program was born during the early COVID era. It was funded through ARPA dollars to ensure that healthcare providers were receiving the support that they need, that you need during that very, very critical time. Then we went on to expand the program because the program was so successful, and we are now being funded through the Behavioral Health Trust Fund, endorsed by the state legislature, as well as the governor, to bring this Gold Star program to communities and healthcare partner organizations across the state. So we are a statewide initiative supporting Massachusetts-based medical and behavioral healthcare workers, non-clinical and support providers in the communities they serve, with workforce support, customized resources, professional trainings, and trauma-informed solutions. What we're up to is building resilience, reducing burnout, and promoting healing for those who provide care and connection to others. This is, again, being funded through the Behavioral Health Task Force And what we're really doing here is supporting anybody in the healthcare world who is providing behavioral healthcare support. That is certainly people with letters after their names who are in specific clinical roles. But as you know about your team and those you lead, healthcare providers across the spectrum are providing mental health resources and support, especially as things have become more difficult in our healthcare system, and as times are getting rough for many people. We're often coming to you, to our healthcare providers, to provide the kinds of resources that we need. And we want to make sure that healthcare providers have the tools necessary to be able to provide that to the patients and populations that you serve. So, who is GPS? Let me just say, what we're specifically doing, which is really important, and I'm going to get into the details, is one, we're supporting your workforce. So we provide mental health resources for your team through structured and trauma-informed support groups that foster connection, reflection, and resilience. We'll talk about that more. We're also building capacity for you to support others. So we'll train your staff to bring these same group therapeutic modalities to your client populations so that you can expand care, you can reduce burnout, and you can strengthen your organization from within. Now, GPS group peer support has been built to provide group therapeutic care for many diverse populations of folks. We work in Massachusetts as well as nationally and internationally. And what we're really focused on is providing trauma-informed and community-based mental health care to communities that have a challenging time accessing them for whatever reason. It could be because of cultural restrictions, language accessibility. It could be because of insurance access, co-pays. It could be population specific. And what we know is that there's not enough mental health care anywhere for the communities that we're serving. We know that there are long wait lists. We know people are often in crisis and unable to get the support that they need. That's where GPS steps in. Our model is successfully implemented by both professionals and peer leaders. And I'll expand the definition of peer leaders. So certainly peer leaders are people who are in the healthcare system, leading through their own lived experience. Perhaps they don't have clinical expertise, or they have training and licensure that gives them the status of a peer specialist or a peer coach. And there are other folks in our healthcare pathway who also provide mental health resources and support to our communities and aren't designated as peer leaders or may not have any training in how to provide mental health resources to the communities they serve. And yet, it is part of their on the ground scope of practice to be running groups for patients and clients. And what we're doing really through this is increasing social support, diminishing isolation, which we will talk about in further depth. And we really want to reignite that commitment to work and realignment with mission. One of the key pieces of this model is that we have built it to be easy to use, to be adaptable, scalable, and cost effective. What we know is that, again, we don't have enough mental health resources for any community that we're serving. We know that the one-on-one dyadic mental health model often doesn't provide enough resource and we can't get people into it fast enough. And so through this model, we can adapt. We can bring this to the perinatal mental health population. We can bring this to diabetes support and education. We can bring this to aging and long-term care communities. We can bring it to recovery for those who are recovering from substance use or other addictive behaviors or challenging behaviors. All right, so let's keep going. I am going to go to the punchline next, and then we'll recircle. But I want to show you and share with you what you can access for your organization at this time through the MASStrong program. So, what MASStrong can provide to your organization, whether you are a small nonprofit, whether you are a community health center or a hospital-based care, whether you're a department within a much larger system, we can provide support groups or group therapeutic care to your community of workers and provide CMEs or CEUs as is appropriate for their own licensure for free. We can do this with you. We can adapt this for your community. This can be something that becomes integrated through whatever means works for your organization. We have flexibility. We want to partner with you to make it work on your side. We also can provide training in how to run our therapeutic group model and help you to adapt that for your unique population. Again, CMEs and CEUs are available for that, and that's free. And then lastly, we can provide $10,000 for implementation to help you to integrate support groups into the way that you support both your workforce and bring these kinds of resources to the clients and patients that you're serving. All right. That QR code is going to get you where you need. We're also going to drop that link, and I'm going to come back to this slide at the end. But I wanted to just let you know that this is what we're going to be talking about, how to really put these tools directly into your hands. All right. So let's start here with a reality check, because we need to talk about what the real experiences of healthcare workers. And again, I'm not going to say anything that you don't already know, that you're not living, either, living because of your role in your organization, or like honestly, like living yourself because you are in the healthcare system and you know exactly what's been going on both nationally at the federal level, at the state level, and certainly since COVID. But I think, or rather, let me say, and I think that it's important for us to name these realities, because without naming them, they become, this unsaid tension and stress that we all live with. And things are tough right now. And I think that being honest about this serves us all. In times like these, feeling stressed isn't weakness, right? It's actually proof that you're awake, that you're paying attention, that you know what's going on. Here's our overview, right? I mean, some of this is just what's been happening for quite a while. We've got healthcare deserts developing around our state. You look at the Berkshires, you look at the Cape, you look at South Shore, right? Even, central Mass, north of Worcester, right? We've got healthcare deserts. We still, even though it feels like a long time ago and we have new problems that are really significant, the impact of COVID is still with us. The burden on our workforce, the burden on our healthcare system. Of course, the Steward healthcare system collapse has had an enormous impact. Again, that kind of feels like old news too at this point, right? Because what have we been up to? Medical science under attack, the diminishment of research dollars, Medicaid funding slashed, health insurance at risk. We've got 65,000 people who might not be able to afford their health insurance in Massachusetts, right? So what does that all mean? More patients, less resources. And in addition to everything else that your team is doing, you're providing mental health care to everyone who comes in the door, because they're coming in upset, stressed out, unable to meet the get their own needs met. And I know we all have both personal stories and stories within our healthcare system in which people can't get access to the care they need, right? So we're really suffering with an enormous number of things, right? So for our workforce, and again, we're not going to go deep in here, but into this, but I do want to just name these things. And again, as I talk about this, I want you to think about both yourself and your workforce, because here's where we are. People are experiencing COVID trauma still, right? We've got PTSD, we've got secondary trauma, exhaustion that, a vacation will not take care of. There's still personal losses and grief that have sat on us that we have not been able to really process. The moral injury was of course, really bad during COVID, that inability for us to be able to do what we need to do therapeutically, and what is medically indicated, because we don't have enough resource, and the pain that that leaves us with, that we can't actually do what we know this patient needs or what these patients need. That's leading to burnout. The isolation between colleagues is enormous because the work has increased, right? We don't have as much time to connect with each other. And we've got job-related illness and injury. I didn't even put on here, we have job-related violence that has been on the increase. And of course, our wages are not keeping up by a long shot with the cost of living, as the cost of living has dramatically increased over the last year. So we have difficulty accessing and prioritizing mental health care, not only to get that for our patients, but for ourselves, right? The challenges for the healthcare workforce, for the institutions, right, is here are the challenges, right? We've got poor and unsafe patient to provider ratios. We've got rising costs of recruitment and training, staffing shortages, high turnovers. Again, I'm not telling you anything you're not living. 5,000 to 7,000 healthcare jobs have been eliminated or put at risk in Massachusetts. They're not going to be replaced, right? And we've got greater difficulty delivering the high quality care that we have grown accustomed to being able to provide in Massachusetts and that we're all so proud of. Our barriers to mental health care, we have limited access to and diminished prioritization of mental health services as we start to see the burden on our healthcare system increase even more. Mental health resources are going to become more and more scarce. So we've got worsening crises for the communities we serve and a lack of training in how to really provide effective support to those we're serving. The mental health care crisis in the US is overwhelmed, fragmented, it's inequitable. We've got rising rates of depression, anxiety, and trauma, which we saw, of course, during COVID. And, again, this is this part of this talk that we're in the midst of, where I'm just going to name things as they are. With the increased stress that we are seeing, and this week as we're doing this webinar, of course, we know that food stamps have been put on hold, that we've got folks who aren't receiving now their second paycheck. We don't know when the end of this particular crisis is going to come, or what the next crisis is going to be. We know that this is going to impact people's mental health. And this is going to, of course, disproportionately impact folks who are low income and who are BIPOC, who live in our rural communities, and some of our urban communities. We've got systemic barriers. Now, here's again the challenge that I was talking about earlier in terms of mental health support, either for our workforce or for the folks that we are supporting, our patients and clients. That traditional one-to-one therapy model fails to meet the needs we have across our populations. We know we've got long wait times, we've got limited provider options, and then we've got all the barriers that we're very well aware of: language, culture, insurance, and workforce limitations. The expectation that we can be immersed in suffering and loss daily and not be touched by it is as unrealistic as expecting to be able to walk through water without getting wet. This is our current situation, right? I know your eyes are open, you're reading the Boston Globe, you're reading and you're following. You know what has been happening, you know what is being proposed, you know what the impact is going to be. So this is the situation for our workforce and for our patients, and quite frankly for ourselves, right? That we are suffering, that we are being touched by this. And just as this says, we can't walk through water without getting wet. So this really builds to, for me, the case for group therapeutic care. Why we need to start to make more and more of a shift to bringing people together in groups. Again, it's effective, it's scalable, it's affordable. We can build community amongst people, whether it's your workforce or the folks you're serving, right? We can allow providers to reach more people without sacrificing quality. In fact, I would argue, and many researchers would argue, that quality improves when we treat people therapeutically in groups rather than individually. and we support their ability to have resilience in the face of the challenges that they are experiencing. So we really need to make a policy and systemic shift, right? So we're reimagining how we do care delivery through group and community-based models. We have to invest actually in the training, certification, and reimbursement for group facilitation, which we're partnering with legislators at the state level, as well as with healthcare organizations and institutions across the state to really look at this. We've got to expand our culturally responsive care and language access and integrate this so that we have peer-led and trauma-informed approaches across all of our settings. So this is really the path towards equity and access. Group therapeutic care, mental health care is a public health solution, not just a clinical tool. If we only shifted 10% of one-on-one dyadic therapeutic care in our state to group care, we would be able to serve 75,000 more individuals tomorrow. We'd be able to prioritize equity, inclusion, and accessibility, and we could shift funding and legislation towards this kind of community-based care. This would help us to build a sustainable, human-centered system where the connection is the medicine and where we're able to do that at a more economical level. But we have a lack of training in group facilitation. Even in parts of our healthcare system where we bring people together in groups, most clinicians are not trained in one-to-one care. They don't know how to lead group-based therapeutic experiences. That increases their stress level. They're unable to make that work for themselves. Graduate programs and professional development rarely include these kinds of skills, whether you're a social worker, a psychologist, a psychiatrist, a peer specialist, a community health worker, an MA, a PA, a nurse practitioner. These are not part of the skills that we train folks in. So people feel unprepared or anxious about running groups. So that means that, of course, we underuse one of the most effective tools that we possibly could. That's where GPS steps in, where we're able to make a shift and we're starting to give the skills back to the healthcare system that we need to be able to serve more people at once. It's imperative that the people who care for our most vulnerable community members have access to care themselves. I'm talking, of course, about the healthcare workforce. Not only do we need to bring this to our patients, we have to bring this to the workforce itself. We know what the burnout rates look like. We know that we are losing healthcare providers and healthcare providers are not coming into the system. And so we really need to make a shift and ensure that we're providing the kind of support that they need to be able to thrive. This is what we believe about healthcare workers. For all of us, for all healthcare workers, our feelings and our concerns are legitimate. Speaking our truth is both a revolutionary act and a transformative act. Our work is important. We deserve the love and care we give others. And together, we can face the challenges before us. Again, it's a moment of crisis. And I think that all the ways that we can figure out to help our workforce feel connected to each other, to be able to have the resilience that they deserve, and to be able to feel realigned with their mission is going to serve us, especially when there are many other aspects of what we're facing that we can't address. We may not be able to increase salaries to meet the cost of living. We may not be able to diminish the demands or the pace that we all need to move at as we lose resources in our health work, in the work that we do as healthcare workers. And so we need to really be able to bring our healthcare workers together to be able to receive the support that they need. That's where MASStrong groups come in. This is where the MASStrong program can provide you with a resource to bring to your team so that they can feel connected and be able to deal with the daily stresses and traumas and hardships and burnout that they experience. The impact of GPS groups is pretty significant. And I'll share some of our research data with you in a few moments. But to talk about what we see when we bring people together in groups we see that when we contradict isolation, the first thing that happens, of course, is a person is able to say, I'm not alone, right? We are able to encourage solidarity and a sense of us. I'm not the only one. I'm not, quite honestly, like I'm not crazy. There's nothing wrong with me that I'm seeing something happening in the healthcare system or it's impacting me in this way. And through that, and again, this sort of goes back to what I was saying. Sometimes we just have to say the challenges out loud, even when we don't know the answer or we can't find an answer in the current circumstances and situation. We are able to, by just naming it, reconnect with our workplace commitment. I remember why I care, even in this impossible situation. And I can prioritize some kind of self care for myself. I deserve to take care of myself. We want to reinvigorate compassion. We know we're going to be dealing with more moral injury, we're going to be dealing with more exhaustion. So we want to remind ourselves that we can make a difference where we can make a difference. We may not be able to make a difference everywhere and for everyone, but we want to be connected to our ability to make a difference. And of course, we want to diminish burnout. We don't want to bleed more employees. We don't want to be in that constant cycle of trying to replace or working with a deficit, which we have been for quite a long time now. So, what we're really doing here is we're addressing one of the symptoms of the current situation in our healthcare system for our workers, which is isolation. Because of the enormous burden of the work, because of the pace of the work, our workforce is more isolated from each other than ever. What we know about loneliness, and we know this, of course, because we all lived through COVID, we know that when we are alone, we suffer. We suffer enormously. The research is really clear about why loneliness impacts us. What we know is that loneliness and isolation is as serious a risk as smoking, that it's a greater risk than obesity. We have a 29% higher risk of heart disease, a 32% higher risk of stroke and premature death, a 50% higher risk of dementia. We also know that loneliness is directly correlated to sleep, to stress, and to impairing immune markers. And of course, it has a direct impact on our mental health, depression and anxiety across all age groups. Again, we lived this during COVID. We saw this in our families and in our community, and of course, in our workforce as well. We haven't moved too far from where we were during COVID. And again, as our resources diminish and our pace has to continue to increase, our workforce is isolated from each other and from other ways that they can receive support. So we want to be sure that we're actually helping them connect with each other to be able to talk about what the current situation is. From folks who were able to come to GPS support groups, which happen mostly online, but can also happen in person. We try to make them as accessible as possible. What we've heard from the workforce who have joined our groups are things like this. Everyone's experience is different, even if it's just a little bit, because every client is different, but we still have a lot of the same things in common that we all go through. So it was good not to feel alone. Being able to share my stories with people who get it and were going through similar things was so helpful. I didn't know what to expect. We hear this a lot. I'm going, but I'm not sure why I'm going. But time flew by and I got so much out of it. And this is a very, very common thing we hear. This was the best therapy session that I didn't know I needed. What I love about this comment is it really speaks in a lot of ways to access, to stigma, and to the benefit of bringing people together in groups to receive peer support that way, that we are going on such autopilot that we don't even realize that we are running with a deficit, that we actually really need support in order to be able to face the challenges that we're experiencing. Sorry, snafu with the slide deck. In the face of relentless demands, deep exhaustion, and the weight of secondary trauma, social support isn't just helpful, it's essential. It's the foundation for healing, resilience, and sustaining the work we do. We cannot and should not carry it alone. So let me go back to this. What MASStrong can provide for you and your organization. One, we can provide support groups for your workforce. What that means is that we can come to your organization, we can learn about it, we can integrate these kinds of resources through your HR, through different departments, through ERGs, and provide support, whether it's in a critical situation because there's been a crisis or it's ongoing workforce exhaustion and burnout, and tailor groups so that they provide support to your community. We also can train your community, your workforce, in how to run the therapeutic groups. We're talking with different organizations, including the Massachusetts Association of Physician Assistants, the National Association of Social Workers for Massachusetts, and other organizations in how to provide this kind of resource to healthcare providers across the state, as well as working with individual community health centers, hospitals, and nonprofits to be able to bring groups specifically to the populations that you're serving. We can develop toolkits and curriculums for your population. So if you're working with diabetes management, if you're working in with communities that are facing heart disease, if you're working in communities that are supporting people in recovery, in pediatric population, in geriatric population, we can specifically develop toolkits and curriculums that you can then bring to the populations you're serving. And lastly, of course, we can bring some financial support. And I know your organizations are large and $10,000 actually isn't a lot, but we hope that it can be a gesture and some support to be able to help you to integrate GPS MASStrong program into your pathway of care, either for your workforce or for the clients that you serve. This is from Duncan Davio, who's the president of the PA Association of Massachusetts. Healthcare providers shoulder the daily weight of patient care, and MASStrong ensures we receive the same support we give others. In a time of unprecedented strain on healthcare, MASStrong is a key tool in helping us to sustain our workforce. I am excited to talk with you about this. We have some time. As I've gone through our slide deck for this presentation, again, on the screen is the QR code that you could click on, or we also are putting the information in the chat so you can learn more about the program and get an opportunity to see more about how this could be brought to your community. And I see Kim, you're back on the screen, so we can have a conversation, see what questions there are, and talk about this some more.
Excellent. Thank you so much, Liz. Really terrific information, very powerful, and definitely, I think, something that is needed out there. Um, if you have any questions, please do put them in the chat. I'm going to start off with a couple of questions, Liz. What inspired the creation of the MASStrong program, and how did GPS identify this as a necessary response to the challenges healthcare workers are facing?
Yeah, well, GPS has been around for a while. We have been building this group therapeutic model, um, looking at the mental health gaps for the perinatal mental health community, as well as for the recovery community, having partnered with the Department of Public Health and Mental Health of Massachusetts, as well as nationally for a long time. And then COVID came, right? And just to be fully transparent and be honest, I'm married to a healthcare provider. I'm married to a primary care doc. And what we experienced as a family was a crisis. He couldn't protect himself or us from seeing patients, especially in that almost year before the vaccine became available to healthcare providers. And the mental health challenges that we faced and that I saw with his colleagues really forced me or provided the opportunity for me to pivot. And what we wanted to do was make sure that healthcare providers had the resources that they needed during that very, very critical time. And so we began offering our therapeutic model to healthcare providers for free. We didn't have the financial resource to do it, but we were committed to doing it. And we did that both across Massachusetts and nationally. We talked with the legislature about this, with the governor about this. And what we then were able to do, and what the state did, was they saw the value of what we were bringing to healthcare providers. They saw the urgent situation and the crisis that healthcare providers were in. And they awarded us $1 million to begin to bring our model to healthcare providers across the state. At that point during COVID, we actually focused on bringing it to healthcare workers um, who were extremely burdened. I mean, all healthcare care providers were, of course, at that time.
Mhm.
But we brought it to home health care aides, long-term care aides, and nursing home care aides. And as we remember in those early months of COVID, that first year, really, that was a group of healthcare workers that had nearly an impossible time to protect themselves in any way. They didn't have access to masks. Um, and there were many, many deaths, as we recall, in our nursing homes across the state. So this was a very high risk population that is also, unfortunately, a low paid population and a very overburdened population. And so we brought this model to them and we saw the success there. And so as we moved forward, we then started to partner with the state, talking to the behavioral health workforce, talking to the leadership in the House and the Senate, in our mental health committees and our healthcare committees. And they wanted to prioritize this program, bringing it to healthcare providers across the state. Now, this was still sort of with COVID, in our front view here. But the moment's changed, right? And now what we see is that the program that we built in response to COVID has a very important role to play right now because our healthcare system, I mean, who would have imagined, right? We would have thought we would have rebounded, we'd be in a different place. But of course, we know that we're not. And we know that things may be getting much harder as we move forward. And so this program becomes really critical at this moment. And we hope that, as many of you as are able to take advantage of this opportunity do so, because we want you to have this resource now when you need it the most.
That's great. Thank you, Liz. And yes, I mean, spot on about everything that was happening. So, we have a question from Simone. That she says, this sounds amazing. Do you provide train the trainer for group facilitation? And it could be great for some peer support programs we're in the process of building.
Oh, excellent. Yeah. Oh, let's talk. Um, So the program is not a train the trainer model. What it is a train the facilitator model. And the reason that it is that way is really because we're very committed to building an evidence base for this model. So the model integrates evidence-based modalities, cognitive behavioral therapy, interpersonal therapy, motivational interviewing, polyvagal theory, psychosocial support, peer-to-peer support. Our trainers are very highly skilled. They have hundreds and hundreds of hours under their belt in running groups for diverse populations. Our trainers also have lived experience. So when we're training any group of people, we're always looking for trainers who have similar experience. So if your folks are leading support groups for people in the recovery community, we have trainers who have had that lived experience as well. And we could go on and on about, that kind of lived experience. So because of that, because of our commitment to the quality of the training, and wanting to be sure that we really support the competence and confidence of all the folks that we train. We do the training, but it's free, it's accessible, it's synchronous and asynchronous, meaning it's live and also recorded, so that folks can really access it. We do it in 3 weeks, we do it in 7 months. If somebody really wants us to come to them, we could also do it in person. So there's lots of ways we make it as accessible on our end. Oh, and I forgot to say, we do it in English and we do it in Spanish. Um,
Great.
And if there was need for other languages, we would be doing it in other languages as well. We've translated our curriculums into Pashto and Dari to serve Afghan communities, into Haitian Creole, into Russian, into Chinese, into Mandarin, and other languages as well to be able to really serve diverse communities effectively.
That's fabulous. Really incredible that you have it translated into all those languages. So that makes it even more accessible. Um, for participating, if for somebody or an organization or individual who wants to get involved, what's the best first step, and what's the best way to reach out and connect?
Well, let's see. You can absolutely email me. I would love that. So you can reach me at liz@grouppeersupport.org. But you can also fill out that, either click on that QR code or the link, complete that, and reach out to us that way, or email us at info@grouppeersupport.org. Um, and this is a little, it's a little bit of a problem in the way we've developed the program on our end, but on your end, what we've wanted to do is make this incredibly accessible. So if you have an idea of how this could really work in your organization, we want to make that work. So we're going to hold the flexibility on our side so that we can really partner with you to bring it to the communities that you serve and the way that your organization is structured. So really, if you're interested at all, please reach out so that we can have a conversation. Really, you'll be sitting down with me because I want to talk to you. I want to hear what the issues and the situation is for you and your organization, and then we're going to think together about how to make this accessible and impactful for your workforce and for the populations you serve. Um, so that's our commitment and our responsibility, and we take that very, very seriously. So just reach out, and we will make that conversation happen as soon as possible.
Great. We've got some other questions coming in from Julia. We have a one-to-one peer support program at Leahy Hospital and use the Betsy Lehman Center, VPSN. How would this integrate?
Oh, yeah. I mean, I think a peer-to-peer model is beautiful. And of course, the work of the Betsy Lehman Center, we all know, is exceptional. So I'm so glad that you have that program in place. Here's how I see most peer-to-peer support programs. Most peer-to-peer support programs in the workforce are identified by someone in the workforce that they need it when they have they have a particular unique crisis that they're experiencing, right? Like maybe there's a medical accident or a mistake, right? That's something that Betsy Lehman Center is really focusing on. Perhaps a tragedy has happened on the floor or in the program that is being held that is impacting folks. When there's a unique situation like that, we really want to make sure that our healthcare providers get support. We want to ensure that it's really at a high level of confidentiality because we know that there's a lot of stigma, and we know our healthcare providers can be really very concerned about how seeking help might impact them, including their licensure and other things like that, right? So we understand that. That needs to stay very, very confidential, and that's a really important training. One of the things that we're talking about at GPS is, in a way, sort of the global stress and trauma that our workforce is experiencing. Now, of course, this impacts us each individually, right? Me as a healthcare provider, right? I'm going to have how it impacts my own mental health, my family, my parenting, my work, etc. But when we come together in a circle, when we come together as a small group of like even 4 or 5 to like 12 or 25, something really shifts, which isn't to say that I still don't have my own personal struggles, but all of a sudden, I realize I'm not the only one, right? It's not just me. It's not just that I'm the only one who can't sleep, or I'm the one who's crying because I couldn't help that patient, or I'm the only one who, feels burnt out and can't dig myself out of a hole. And there is something about holding that collectively that starts to build group resilience. It's an interesting thing. After September 11th, the PTSD numbers were actually not nearly as high as you would imagine that they would be. right? When you look at those stats, why? Because we held it as a community, because we were dealing with a trauma collectively. And that's where this model starts to shift us, right? So I don't see, so in again, back to the question of the peer-to-peer. In the peer-to-peer, it's often that one person has identified for themselves that they need support, or maybe their supervisor has and is helping them on that pathway. Here we're doing it collectively, right? So here we're saying, you know what? We're all stressed. As your supervisor, I'm going to show up. I want all of you to show up. We're going to do this. We're going to do it quarterly. We're going to do it once and see how it goes, whatever it is. And we're all going to come together and say, this is really enormous pressure on us all. So that's where we start to make a shift. It's almost like thinking about this as like public health. This is like a public health intervention for our workforce so that they feel more connected to each other. And we're not sort of, again, like focusing on one person and the challenges and struggles they have. Now, that said, if folks learn this model, it helps enormously on in any one-to-one relationship they have, whether it's supervisor to those they supervise, whether it's as provider to client or patient. And certainly this model can be integrated into supervision when you're doing group supervision with your team. So there's a lot of flexibility there. And I think that they are wonderful partners together to have the group therapeutic support model with the opportunity for there to be the peer-to-peer when that is indicated and when that is appropriate for somebody in your workforce.
Great. Thank you, Liz. Another question. It's amazing to hear the details and modalities utilized by the trainers. Is there any written material or curriculum utilized for trainings? I think one of the difficulties is asking leadership or systems for time for individuals and teams to get trained, and knowing what might be entailed is helpful to advocate for that.
Absolutely. Yes. So we have manuals, we have curriculums, we have power. I could I could give you as much as you might want to look at and share, as well in, sort of a more succinct way to be able to share with leadership. Um, what we're really doing in our training, which is about 17.5 hours. It's significant. It's not a brief training to be a facilitator. That's different than if you want your folks to attend a support group, right? If you want your folks to attend a support group, we'll come in with the expertise and we'll lead it for you. And what will that take for your team? 1.5 hours, or you tell me how much time you have, and we'll get CEUs for your team. Okay, so that's very, very, very light lift. If you want to integrate this into your workforce and you want your folks to have these skills to either be able to run groups for staff or be able to run groups for clients and patients, that's a 17.5-hour training. We do it in 2.5-hour modules. There are 7 of them. And again, they're live or they're recorded so that they can be really accessible. And we hear that they're just as good recorded as live, which we really strive for. We have a really exceptional training team, so they're incredibly engaging. So we're teaching all of those modalities, okay? CBT, IPT, motivational interviewing. Okay, but not like, okay, now we're going to do CBT. It's more like it's woven in there. So if you know CBT or you know motivational interviewing or mindfulness-based stress reduction, you will certainly identify it and know that. If you don't, it's kind of seamless. And we teach so that we always give, some amount of framing around the modalities that we're basing that part of the model on, but we very quickly get to pragmatics. What are the skills you need? What are the scripts you need? How do we do the cultural co-creation so that it's really specifically designed for your team? And all of that flows really beautifully. So yes, I'm very, very happy to give you more materials, give you specific descriptions that we've developed so that you can share it with leadership and whoever you want. And just reach out to me and we'll make sure that you have that.
Excellent. That's terrific. Thank you so much. I bet that will be helpful for a lot of folks.
Yeah,
Thinking
absolutely.
about sustainability of this, I know MASStrong's offering up to $10,000 in funding for organizations. How is this funding intended to support the long-term integration of the model into healthcare settings?
Yeah, well, again, like let's just I'm so glad we have $10,000 to give, and I know it's not enough. So, I'm both grateful and I apologize that it's not nearly enough. But what I hope is that it can allow you to start to think about the ways that you can integrate. So, some of our partners, for instance, are using the money to be able to support salary of staff so that staff can get trained, are able to cover other expenses. They're using it for marketing and messaging. They're using it for administrative support. They're using it to be able to provide resource for the focused team that needs to help develop the co-created curriculum with us. So the money can be used that way. I think that in the conversations that we will have following this webinar, we're really going to talk about what would make sense for you to integrate. Look, here's the reality of it. We've got funding through fiscal 2027. And then we might not have fun, right? Like we know what the reality is in Massachusetts and nationally. We may not have the funding. My goal is for you to have this tool so that if the funding disappears or when it ends, you're able to continue and have this resource for yourself and for your organization. What's that going to mean? You're going to need to invest in training some folks. You're going to need to invest in some curriculum design. Um, and we need to get started because, again, we don't know exactly what's happening or what decisions the governor might need to make in the months or next couple of years. Excuse me. So, my recommendation to you all, if you're interested in this program, knowing that sometimes things can take a long time in all of our organizations to move forward, is don't wait. Don't hesitate. Like, start now, and let's get this into your hands.
I think that is an excellent place to close. And we will, as a reminder, we are sending out the slides. This is recorded, and we will send you the recording. And Liz, any materials or information that you can share, certainly we'll have your contact information that we can share with everybody. That'll all go out to everybody who registered for this event. Thank you, Liz. This has just really been a tremendous webinar, really informative. Looks like a lot of people are interested, and hopefully you'll hear from some of them very soon. So thank you for leading this wonderful session today. And thank you all who registered and attended today for joining us. If you scan your QR code on your screen, you can see all of MHA's upcoming educational programming. We have a lot of webinars and in-person events. Most of the webinars are free and available. You can share those with your networks. And then we also have these other in-person events upcoming. We've got the Women's Conference in December and our annual meeting in January. So we hope to see all of you at future events. And thank you. I hope you enjoy the rest of your day. Thanks again, Liz.
My pleasure.